Hello and good evening, everyone. Welcome to our 50th BlueHealth virtual seminar. BlueHealth virtual seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by BlueHealth Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Dr. Adela, a general physician and first aid trainer from BlueHealth Ethiopia. Today, it's a pleasure to have Dr. Anteneh Mitiku here with us to give a presentation on the approach to hyponatremia. Dr. Anteneh Mitiku is an emergency medicine and critical care specialist at Yekatit Ashraullet Hospital.
Good evening, I'm Anteneh. So we're going to see about the approach to hyponatremia. So as an introduction, the total body water accounts for approximately 60% of the total body weight, and it's divided between the intracellular fluid and extracellular fluid compartments. And the extracellular fluid compartment is composed of intravascular fluid as well as extravascular fluid. So from this diagram, as you see in an adult male, around 60% of the total body water, the total body weight is composed of fluids, while in female around 55% of the total body weight is composed of fluid. And this composition will vary based on age of the patients. So in old age males, the total body water is around 50%, of the total body weight, while in old age females, it is around 0.45%. Out of the fluids, 2/3 is found in the intracellular space, while 1/3 of the fluid is found in the extracellular space. So water moves freely between the intracellular as well as the extracellular fluid compartments based on the gradient of the solutes, while movement of electrolytes is maintained by ATP requiring channels, but water can move freely between the intracellular space and extracellular space, but ions can't move between the extracellular and intracellular space. So extracellular space is composed of 80% of the interstitial fluid and 20% of the plasma. So ions can freely, ions as well as fluids can freely move between the interstitium and the plasma, while the contents of the plasma, which are large enough, will not pass through the capillary membrane between the plasma and the interstitium. So the electrolyte content of the interstitium is almost similar with the plasma. So seeing the electrolyte compositions between the different parts of the body fluids. So the predominant cation in the extracellular fluid is sodium, while the predominant cation in the intracellular fluid is potassium, followed by magnesium and small amount of sodium. So the predominant anion in the extracellular fluid, that means in the intravascular space as well as in the interstitium, is chlorine, and the commonest intracellular cations are phosphates, as well as some effect from bicarbs and proteins. So this will help us as we continue our discussion. So coming to the common terms used in water balance, osmolarity is the total number of particles in a solution per liter. So this is going to be affected by the temperature as the characteristics of the water is changed with temperature. So in clinical practice, we usually use the osmolality rather than the osmolarity. So the osmolarity is the number of particles per kilogram of the solvent, which is not altered by the difference in temperature. So determining osmolality is important because it indicates the water balance of the body. So water moves from low osmolality space to or fluids to the higher osmolality fluids, or from spaces with higher solutes from the body spaces with a lower amount of solutes. So the normal plasma osmolality is between 275 and 295 milliosmol per kilogram. And some texts gives us the reference range of between 275 to 290. So a value greater than 295 indicates that the concentration of a particle as compared to the water is high in that compartment, or it tells us there is a little water. So values less than 275 milliosmol indicates there are a little solutes for the amount of water, or there are too much of water for the amount of solute. So as the amount of water increases, then the osmolality drops. As the amount of solute increases, the osmolality also increases, or as the amount of the solute gets lower, then the osmolality also gets lower. So the major determinants of the plasma osmolality are sodium and glucose, and we usually use the formula 2 times sodium plus glucose over 18 plus BUN over 2.8 to calculate for osmolality. So we divide the glucose and by 18, as well as the BUN by 2.5 to change it to millimole, because most of the time the glucose is, and the BUN is expressed in milligram per DL. But if they are expressed in millimole per liter, then there will not be a need to divide by 18 as well as 2.8. So the normal range, as I mentioned earlier, will vary between 275 to 290 to 295. So rather than the total osmolality, which is defined by the amount of solutes in a given weight of water. So when we talk about water balance, effective osmolality or the tonicity is the one which affected the movement of water between the intracellular as well as extra cellular fluid compartments. So effective osmolality is mainly due to the sodium salts with small contribution from glucose. But if you recall from the previous formula in determining osmolality, we use BUN2. But BUN is an effective osmol, and ineffective osmol means that the BUN moves between the body compartments or between the intracellular fluid as well as between the extracellular fluids freely. So it doesn't determine the tonicity of the extracellular fluid compartment. So sodium is mainly found in the extracellular fluid, and sodium and glucose are the main determinants because they didn't cross or they didn't freely move between the intracellular space as well as the extracellular space. So the other ineffective osmoles that may increase the osmolality, but that may not affect the total movement of water include like I have mentioned urea. The others are like alcohol, glycerol, and the likes. They may increase the osmolality, but they may not affect the water movement between the two compartments of the body. So effective osmolality or tonicity is mainly calculated by calculating 2 times sodium. So we multiply sodium by 2 for the amount of cations which are found in the extracellular fluid, which are comparable with the amount of sodium which is found in the extracellular fluid. That's why we multiplied by 2 the sodium amount so that we can incorporate the anions which are found in the extracellular fluid too. So coming to sodium, as I said earlier, sodium is the main cation in the extracellular fluids and plays a major role in maintaining the concentration and the volume of the extracellular fluid. So sodium imbalance are typically associated with parallel changes in osmolality. That means if there is a drop in sodium, then we'll expect a parallel change in osmolality because sodium is the main constituent which determines the plasma osmolality. So in the setting of hyponatremia, if the osmolality is not changes or if it doesn't decrease, then the hyponatremia may not be a true one because sodium constituents it's a major constituent of the effective tonicity or the plasma osmolality. So the kidney regulates the extracellular fluid concentration of sodium by excreting or retaining water under the influence of ADH. So when there is a decrease in an increment in osmolality of the body, that will make the pituitary glands to release the ADH, which subsequently acts on the renal tubules and with the retention of water and reduction of the osmolality, or vice versa in the case of decrement in osmolality, then there will be a increased secretion of ADH. So aldosterone also plays a role in sodium regulation. So when there is a decrement in the total body water, or when there is a decrement in blood pressure or effective circulating volume in the body, that will result in activation of the RAS system, which end up in release of aldosterone, which reabsorbs sodium in the renal tubules with and which also excretes potassium. So hyponatremia is defined as serum sodium concentration less than 135 milliequivalent per liter. So hypernatremia is primarily a disorder of water balance. So in a given solution with containing sodium, so if there is an increment in water amount, then the sodium concentration will go down. Or in a given solution where there is constant sodium level, if the water amount is reduced, then the concentration of sodium is increased. So hyponatremia, or when we talk about sodium, we are primarily talking about disorders of water balance. But still, hyponatremia can result due to loss of potassium containing fluids, or due to an increment in water content of the body fluid compartments. So if a patient is hyponatremic, then that will cause hypoosmolality, because as I mentioned earlier, sodium is the main cation which determines the osmolality. So the decrement in osmolality will shift water into the cells from the intravascular space. So the concentration of sodium does not give us information regarding the volume status. So the first step in evaluating patients with hyponatremia is clinical evaluation of the extracellular fluid status, plus calculation of the measured as well as calculated plasma osmolality. So intro hyponatremia, so which we'll discuss subsequently, there will be a reduction in osmolality, as I mentioned earlier. So if the sodium decreases, we'll expect also the plasma osmolality to decrease. So the first step is determining the osmolality as well as the volume status of the patient in approaching patients with hyponatremia. So based on the tonicity, or based on the osmolality, we can divide hyponatremia into three: hypertonic hyponatremia, normotonic or eutonic hyponatremia, and hypotonic hyponatremia. So hyperosmolar or hypertonic hyponatremia occurs when large amount of osmotically active particles accumulate in the in the extracellular fluid space. So that means if there is accumulation of other osmotically active solutes other than sodium, that means like glucose, or the main cause of hypertonic hyponatremia is hyperglycemia, or other osmotically active particles like mannitol or alcohol. So this will increase the extracellular fluid osmolality. So in this setting, there will be a net movement of water from the intracellular fluid to the extracellular fluid, thereby effectively diluted the extracellular fluid sodium. That means there will be a decrement in the sodium concentration due to movement of water from intracellular space to the extracellular space. So this happens commonly with glucose, because one of the components which determine plasma osmolality with sodium is glucose. So for patients with hyperglycemia and hyponatremia, we need to correct the serum sodium level to see whether the patient has hypertonic or hypotonic hyponatremia. So as a consensus, so for each 100 milligram per day increment in plasma glucose level above 100 milligram per day, so the serum sodium will decrease by 1.6 milliequivalents. That means we need to add 1.6 milliequivalent in each for each 100 milligram per deciliter increment in glucose above 100 milligram per day. So we can equate the actual sodium level by using the above formula. So in case of hyperglycemia, then there can be hypertonic hyponatremia and other causes, as I've mentioned earlier, like mannitol, glycerol, maltose. This will cause an osmolar gap and hyponatremia. So osmolar gap is the difference between the measured osmolality and the calculated osmolality. So the measured osmolality is usually measured in the labs. So it is going to measure every osmotically active particle in the intravascular space or in the blood. So that may include the mannitol, glycerol, maltose, and the like. But we usually calculate the osmolality using the sodium and the glucose, as I have mentioned earlier, because the other solutes are ineffective osmoles, and they move between each compartment of the body fluids freely, and they will not affect the movement of fluid between the two compartments. So if the difference between measured osmolality, which is measured with lab, and the calculated one, so usually the normal is around 10, and if it is greater than 15, that means there are non-detectable agents with osmotically active non-detectable agents are present, causing osmolar gap and causing hyponatremia. So in this case, there will be associated in hypertonic hyponatremia, then there will be associated osmotic diuresis that subsequently normalize the amount of water in the extracellular fluid, and that will subsequently normalize the sodium concentration. So in case where there are osmotically active particles, which may increase the tonicity, that means in patients with hypertonic hyponatremia, then the measured osmolality is usually going to be greater than 290. The other is isotonic hyponatremia. So we usually call this pseudo hyponatremia, and that is a falsely low sodium reading caused by the presence of other osmolar particles in the serum. So like patients with hyperlipidemia and hyperproteinemia will end up developing isotonic hyponatremia. So high concentration of lipids and the proteins will displace the serum water, which causes laboratory misinterpretation of the sodium. Usually this type of patients, even if they have low sodium, so they will be asymptomatic and we don't need to treat. So most of the conventional labs are affected by the high level of protein and glucose. So we can use ion selective labs or ABG, which measures the sodium ions in the plasma and which will not be affected by displacement of the serum water. So as I have mentioned earlier, so if there is true hyponatremia, then it will be accompanied by hypotonicity. So a reduced sodium level will result in a reduction in tonicity too. So usually the tonicity is going to be less than 275 milliosmol per kg. So once we have identified that the patient has hypotonic hyponatremia, then the next thing is evaluating the patient's volume status. So we can divide that based on the patient's volume status into hypovolumic hyponatremia, normovolumic hyponatremia, and hypervolumic hyponatremia. So hypovolumic hyponatremia, it is usually caused by volume depletion and a subsequent decreasement in extracellular fluid volume, which is associated with loss of sodium. So the usual mechanism is a decrement in the circulating body fluid, which will cause the secretion of the ADH. Subsequently, there will be antidiuresis and reabsorption of water, and which result in net decrement of the sodium level. So the cause of hypovolumic hyponatremia can be renal and non-renal causes. So non-renal causes like vomiting, diarrhea, start space losing, which result in markedly reduced effective circulating blood volume, which subsequently is sensed by the baro or receptors, and there will be a release of the ADH, which will result in hyponatremia. The other are renal causes. So renal losses can be due to diuretics, and the commonest diuretics is thiazide diuretics. So it is assumed that thiazide diuretics directly induce the release of vasopressin, or it will increase the response of the collecting to circulating vasopressin. The other cause of renal losses are like osmotic diuresis from osmotically active substances, like when we give mannitol to patients as a treatment. So subsequently, there will be osmotic diuresis. So if there is significant loss of water as compared to the sodium, that may result in hypovolumic hyponatremia. The other is adrenal insufficiency. So in adrenal insufficiency, there will be a decrement in aldosterone level. So hypoaldosteronemia will result in renal sodium loss due to the loss of the sodium reabsorption, which is due to the hypoaldosteronism. So there will be loss of sodium reabsorption, so which will be also accompanied by water. Always sodium is accompanied by water, and there will be a decrement in total body water amount, so which will result in a decrement in contracted extracellular fluid and hyponatremia. The other cause is cerebral salt wasting syndrome, or the renal salt wasting syndrome, which usually is caused in patients who have intracranial pathologies like subarachnoid hemorrhage. And it is the mechanism is possibly from the hypoaldosteronism, and so which will result in subsequent reduction of body fluid, as well as decrement in sodium amount due to loss of reabsorption of sodium. So there are different mechanisms which are mentioned as a possible cause of hyponatremia for patients with cerebral salt wasting syndrome. So normovolumic hyponatremia, patients are clinically euvolumic, but due to an increased activity of ADH, patients will have increased total body free water, which leads to hyponatremia. But patients usually will not have signs of fluid overload like edema, pulmonary peripheral edema, pulmonary edema, ascites, and the like. So the most common cause is SIDH, so syndrome of inappropriate antidiuretic hormone secretion. And the other is glucocorticoid deficiency. So cortisol has a direct effect on release of a direct suppressive effect on release of ADH secretion. So the other is glucocorticoid deficiency, and the cortisol has a direct suppression effect on ADH secretion. So the deficiency of glucocorticoids will result in unopposed release of the ADH secretion from the pituitary that will result in increased total body free water. So hypothyroidism and patients with psychogenic polydipsia. So patients who took a large amount of water. So there will be urinary excretion of water in this setting, but the amount of water, if the amount of water ingested is more than that is excreted by the kidney, then patients will end up developing normovolumic hyponatremia. So usually this type of patients, they may not have overt sign of fluid overload, but actually due to the activity of the ADH, there will be retention of fluid, which will result in an increment in the total body free water. So the other obvious one is hypervolumic hyponatremia. So patients with hypervolumic hyponatremia will have signs of hypervolemia and hyponatremia, mostly due to the excess free water, which will result in a net decrement of sodium concentration. And there may be also associated loss of sodium. So edema forming states like congestive heart failure and cirrhosis may end up, patients may end up developing hypervolumic hyponatremia. So this is also due to a decrement in effective arterial volume or effective circulating blood volume. So which is the volume of blood perfusing the tissues. So in case of congestive heart failure, due to decrement in cardiac output, and in case of cirrhosis due to arterial vasodilation, so will be sensed by the baroreceptors as a decrement in the effective arterial volume. And this will result in subsequent release of ADH that subsequently result in excessive free water retention. Patients with nephrotic syndrome, most of the time, they may not have significant hyponatremia unless they develop concomitant hyponatremia, because the effective arterial volume is not affected in those patients with nephrotic syndrome. So coming to the clinical presentations, so the symptoms are vague and non-specific for hyponatremia. So there are typically two factors which influence how symptomatic a patient will become as a result of hyponatremia. One is the severity, that means the level of the hyponatremia. So usually patients become symptomatic when the sodium level becomes less than 120. And the other is the acuity of the onset of the hyponatremia. So if the hyponatremia is acute, then patients will also be symptomatic. So the lower the sodium and the faster the fall of the serum sodium level, the more symptomatic a patient will be. So if the sodium falls faster and if the level is low, then this type of patients will be more symptomatic. So determining the severity of the hyponatremia. So mild is between 130 and 134, while moderate 120 and 100. The severe is less than 120. So complications of untreated hyponatremia and complications from overcorrection of hyponatremia are most common among patients with severe hyponatremia. So the other factor, as I have mentioned earlier, is the duration of the hyponatremia. So if hyponatremia develops in less than 48 hours, then it is an acute one. But if the duration is unknown and if the hyponatremia develops in more than 48 hours, then we'll assume that the hyponatremia is a chronic one. So mostly if patients are presenting from home with hyponatremia, and usually it is considered to be a severe a chronic hyponatremia. The more acute the hyponatremia, then there is a greater risk of complication, because it doesn't give time for the brain to adapt for the extra cellular fluid compartment, the decrement in sodium level in the extra cellular fluid compartment. So the risk of cerebral edema and the seizure is greater in this type of patient. So when there is a sudden drop in serum sodium level, then water will move, or water will shift from the intravascular space to the cells. So there will be edema formation in the brain cells, so that usually will end up in cerebral edema, even brain herniation, if the hyponatremia occurs acutely in patients like who are taking a lot of water, like marathon runners, or those patients with primary polydipsia, where there is a significant intake of water, which result in acute decrement in sodium level. So that will result in movement of water from the intravascular space to the cells. So, and that the brain will not have a time to adapt. So patients usually may develop severe neurologic manifestations like coma, brain herniation, and death. By contrast, seizure and other neurologic manifestations are relatively uncommon in patients with chronic hyponatremia, even with in those patients with a low serum sodium level. So the more chronic the hyponatremia and the lower the serum sodium concentration, then the greater risk of complication from aggressive treatment. So the more acute the hyponatremia, there is a greater risk from complication from the hyponatremia itself. The more chronic and the lower the serum concentration level, so there will be greater risk of complication from aggressive management of the hyponatremia, which will result in osmotic demyelinating syndrome. So patients with hyponatremia may present with mild to moderate symptom. We usually call them non-severe symptoms, like which are mostly non-specific, like headache, fatigue, lethargy, nausea, vomiting. Patients may have gait disturbance. They occur most commonly in patients with chronic hyponatremia, those patients presenting for more than greater than 24 hours, and for with those with a low sodium level, which is 120 milli equivalent. So in this type of patients, due to the brain adaptation and the likelihood of developing cerebral edema will be low. So patients with chronic hyponatremia with severity less than 120 may manifest with mild to moderate symptoms, or with non-severe symptoms, and they are not usually associated with severe symptoms of hyponatremia, because it gives for the brain time for adaptation. But if the serum sodium level is less than 110 milliequivalent, so such symptoms like fatigue, headache, nausea, and vomiting should alert us that the subsequent development of severe symptoms of hyponatremia is imminent. So the severe symptoms of hyponatremia is defined as any biochemical level of hyponatremia in the presence of severe symptoms. So these are due to movement of water from the extracellular fluid to the brain cells, usually. So these are seizure, coma, brain herniation, which result in respiratory arrest and subsequently death. And that is relatively common in patients with acute and marked reduction in serum sodium concentration, as I have mentioned earlier. If it is a chronic one, because it gives time for the brain to adapt, then the likelihood of patients presenting with severe symptom is low. But if the level of the sodium is less than 110, development of non-severe symptoms will give us a clue that the patient subsequently may end up in developing severe symptoms. So the other group of patients with hyponatremia may present asymptomatically. So many hyponatremic patients with mild hyponatremia will be asymptomatic, or they may have subtle change in mentation and the gait, and they may have an increased risk of falls and fractures. So it is usually normalized with chronic therapies based on the patient's disease entity. Patients may be given table salt, patients may be given furosemide, and they like to prevent subsequent drop in the sodium level, which may result in severe or non-severe symptoms. But patients with moderate hyponatremia may present with mild symptoms, or they may not even have symptoms. So the diagnosis of hyponatremia is usually based on the lab result of sodium, but the diagnosis of the subtypes, as I have discussed earlier, is based on the volume status of the patient, and with some measurement value. So like we can measure the serum sodium level, we should measure the serum sodium level, serum osmolality. So serum osmolality can be measured from a glucose and the sodium. So as a trend, it is good whenever we request for serum electrolytes to draw blood glucose level simultaneously to calculate the serum osmolality. And the other is determining the patient's volume status from history and physical examination, and determining the urine sodium, which we usually don't do it, but urine osmolality can be calculated or can be estimated using the specific gravity. So we can take the thousands and the hundreds and the thousands decimal place of the urine the urine specific gravity as a whole number, and we can multiply them by 35 to obtain the urine osmolality. So as an example, if the urine specific gravity is 1.005, then the hundreds and the thousand decimals will be 0.5, and we can multiply that by 35, and that will be 175 milliosmoles per liter. So this will give us a rough estimation of the urinary osmolarity. So usually if the specific gravity is less than 1.0110, then we will assume then the urinary osmolality is low, and if it is greater than 1.010, then we'll assume the urinary osmolality is high. That means if the last two decimals are 1 and 0, then 10, that will be 10 times 35, then the urinary osmolality is greater than 350 milliosmol per liter. So as a general rule, the urine sodium will be less than 20 milliequivalent in those patients with edema forming syndromes like heart failure or cirrhosis, or in those patients with vomiting and diarrhea. In the other group of patients where there is a loss of sodium, so we usually expect the urine sodium to be greater than 20 milliequivalent per liter, which we don't determine most of the time in our setup. So we can determine serum osmolality from the glucose and sodium level. We can assess the volume status based on the history, physical examination. We can calculate the urine osmolality based on the specific gravity, as I have mentioned earlier. So based on the laboratory abnormalities, we can group different types of hyponatremia. Then we can see the serum osmolality, urine osmolality, and urine sodium level. So in patients with pseudo hyponatremia, like in patients with hyperglycemia, so usually the osmolality is going to be, the serum osmolality is going to be high, because sodium is one of the components of the one of the components which determine the osmolality. So the osmolality is going to be high, but the urinary osmolality as well as urine sodium is going to vary. So urinary osmolality, if there is associated osmotic diuresis, then the urinary osmolality is going to be low. But if there is no associated osmotic diuresis, then that will be high. So there will the urine osmolality will be variable. So coming to patients with with heart failure, so we'll expect the serum osmolality to be low. They usually have hypotonic hyponatremia. Then the urine osmolality will be high because of the ADH activity. So there will be reabsorption of water, and there will be excretion of concentrated urine with solutes. So that will give us high urine osmolality. And the urine sodium, unless it is with patients with end-stage renal disease where there is inability of concentrating the sodium, and where there is a loss of sodium, then the urine sodium is going to be low. So the two cause of hyponatremia, where the urine sodium will be low, is when in patients with hypervolemic hypernatremia, and in patients with hypovolemic hyponatremia secondary to GI or non-renal causes. The other is SIDH. So in SIDH, so there will be a release of antidiuretic hormone, and there will be excretion of concentrated urine. So that will result in an increment in urine osmolality. And there will be associated loss of sodium in patients with syndrome of inappropriate antidiuretic hormone secretion. So we'll expect the urine sodium to be high. So coming to the treatment, so the treatment of hyponatremia is guided by the severity of the symptoms and estimated duration of the illness, whether it is acute or chronic, or the fluid status of the patient, whether the patient is hypovolemic or hypervolemic, and based on the underlying cause of the sodium disturbance. So the most important guide for therapy for patients with hyponatremia is the development of the severe symptoms rather than the sodium, rather than the actual sodium level. So when a patient presents with severe neurologic symptoms like seizure, reduced consciousness, with sign and the symptoms of cerebral edema and the herniation, the initial treatment with 3% hypertonic saline is indicated. So when symptoms are mild or moderate, or in chronic hyponatremia, so sodium should be corrected slowly. So rapid correction of sodium will lead to complication of treatment, which we call it osmotic demyelinating syndrome. For chronic hyponatremia without severe symptoms, so we usually it is usually advised to correct the sodium by 6 to 8 milliequivalent per 24 hours, which typically occurs in 2 to 3 days. So what are indications for IV bolus hypertonic saline treatment? So if the serum sodium level is less than 120 milliequivalent per liter, and if the patient presented with severe neurologic symptoms, so the mere presence of sodium less than 120 is not an indication for treatment with hypertonic saline. But if a patient presents with severe neurologic symptoms, then that is an indication for treatment with hypertonic saline. And the other indication is in acute symptomatic hyponatremia, as I have mentioned earlier, because of the complications we expect with hyponatremia rather than with treatment, due to movement of fluid to the intracellular spaces, mainly to the brain, resulting in cerebral edema and herniation, respiratory arrest, and death. So patients with acute symptomatic hyponatremia also needs to be treated with hypertonic saline. So the principles of treatment of hyponatremia start with treatment of severe hyponatremia, or those patients with symptomatic hyponatremia. So acute symptomatic hyponatremia. In acute symptomatic hyponatremia, or in the patients who had severe symptoms, so the goal is to increase the serum sodium level by 4 to 6 milliequivalent per liter. And we usually target a 5 milli equivalent increase in sodium. And this can be done by infusing 100 to 150 ml of hypertonic saline over 20 minutes. And we need to repeat the electrolyte panel after 20 minutes to see for the increment in the sodium level. So if the goal is not achieved, then we can repeat the dose for 2 to 3. So for a total of 3 times. So 100 ml, 100 to 150 ml for a total of 3 times. If the sodium has increased by 6 millimoles or milliequivalent, and if the symptoms have not resolved, then hyponatremia isn't the cause of the symptom, the patient's symptoms. So an increment in sodium level of 5 milliequivalent or maximum of 6 is enough to abate the severe symptoms of hyponatremia. So if the symptom persisted, then it's good to further evaluate patients for alternative or additional diagnosis. But in our setup, we don't usually found IV 3% saline. So we can prepare oral solution containing 3% saline or 3% sodium, which is around 513 millimole of sodium. So in 1 liter of hypertonic saline, there is 513 millimole of sodium. So to prepare that, so it's estimated that 1 teaspoon of table salt contains about 6 grams of salt, which is approximately 2,400 milligrams of sodium. So to change this to millimole, so a millimole is 1 millimole is equal to the molecular weight of that particular ion. So for sodium, so the molecular weight is 23 milligrams. So 1 millimole of sodium is equal to 23 milligrams. So to change the sodium to millimole, then we can divide 2,400 to 23, which gives us around 104.5 and around 104.5 millimoles. So 1 millimole of sodium is equal to the molecular weight of the sodium, which is around 23 grams. And to change the sodium in milligrams to millimole, then we can divide it with 23, which gives us around 104 millimole. So to prepare a 1,000 ml of standard 3% saline or 3% hypertonic saline, so this is a solution which is going to be given PO. It's not an IV hypertonic saline, which contains 530 millimole of sodium. Then we can add 5 teaspoons of salt into 1,000 ml of water. So 5 times 104, then 5 times 100, it is 500. Then we 4 times 5 is 20, 520, which is almost equal to 513 millimole of sodium in 1,000 ml of NS. So this solution can be given PO. So the volume of the solution which is needed to be given to rise the amount of sodium by desired level can be calculated. So first we need to calculate the expected change in serum sodium from the infusion of a liter of saline solution. Second, we need to determine the portion of the liter required to write the sodium by the desired amount. So to calculate the expected change in serum sodium after infusion of 1 liter of IV saline, we can use the formula below. So it is for an IV saline, but still we can, for resource limited areas like us, we can use it for PO2. So the expected change in serum sodium equals infused sodium minus serum sodium over total body water plus 1. So expected change in serum sodium, infused sodium is the amount of sodium which is present in the fluid which we are going to administer, and the serum sodium is the patient sodium level. Then the total body water is determined based on the patient's age and the sex. So for male adults is 0.6 of the total body weight. Female adults around 0.5. Elderly males it is around 0.5, and elderly females it is around sorry, it is around 0.45%. So as an example, you desire to increase the serum sodium level of a 68-year-old male having seizure secondary to sodium level of 150 milli equivalent per liter using 3% saline, and the man weighs 60 kg, and your target is to increase the sodium level by 6. And here is the formula to calculate the expected change in serum sodium. So you can calculate the amount of fluid or 3% saline needed to be given for this patient, and forward it in the queue. And so based on our formula earlier, so to calculate, first we will calculate the total body weight, which is 0.5, because this is an elderly patient of 60 kg, which will be 30 liters. So change in sodium expected. So infused sodium. So we're using 3% saline, which is around 513 minus the serum sodium, which is 115 over 30 plus 1, then you will get a result of 12.8 milliequivalent. So every 1000 ml of 3% saline, it is an IV one, will give you a rise in serum sodium of 12.8 milli equivalent. So the target is to increase by 6 milli equivalent per day. So if the 1000 ml increases the serum sodium by 12.5, then how many ml is required to increase the serum sodium by 6 milli equivalent? Then we can multiply 1000 by 6, then that is 6000. We'll divide it by 12.8, and we need 468 ml of hypertonic saline to increase the serum sodium by 6 by 6 milli equivalent. So there are some comments that infused sodium is the amount of sodium in the given solution. So for example, if our infostate is normal saline, then the amount of sodium in the normal saline is 153. So rather than 513 here, then we're going to use 153. So if you are using 3% saline, so the amount of sodium is 500 in 513 in 1000 ml of 3% saline. So this is for PO1, but we can still use it for this is for an IV1, but we can still use it for PO for our setup. So after preparing 1000 ml of PO 3% saline with the preparation I have mentioned earlier. So adding 5 teaspoons of salt in 1000 ml of water. So this contains around 513 or around 520 millimole of sodium in 1000 ml of water. So we have prepared a PO 3% saline. So with this formula, we need around 468 ml of hypertonic saline or the 3% PO saline to increase the sodium by 6 milliequivalent per day. So this can be divided by 12 and it can be given every hour. Or in case of severe symptomatic hyponatremia, where we want to treat patients within hours, then this can be given in 3 hours, like around 150 ml per hour, and we can set the sodium level. And if it is not corrected, we can give them for a second time, measuring the serum sodium amount. The thing is, this is the PO1. So this formula will give us the amount of the solution needed to increase the serum sodium level in those patients taking IV fluid, IV 3% saline. But if they are taking a PO1, then the absorption is erratic. We don't know. We don't actually know the increment in the serum sodium level, but in resource limited setups like us, we can use PO 3% saline. So the problem with this formula is it doesn't account the water diuresis that accompanies with the administration of sodium. So when we administer sodium, and when the sodium is corrected, then there will be subsequent decrement in ADH secretion that will result in water loss. So that should be calculated to actually know the amount of sodium increment due to the fluid which is given. And as other, this formula also doesn't incorporate the other cation, which is also affects the water movement at the potassium during therapy of sodium. So when the level of sodium increases, so the sodium potassium ATPase, so there will be movement of due to activation of the sodium potassium ATPase, and there will be movement of potassium into the cells and the sodium out of the cell to intravascular space, that which subsequently increases the serum sodium level. So this can give us a formula which will help us to predict the rise in the sodium level from a given solution, but it doesn't actually incorporate the amount of fluid loss that results secondary to the correction of the hypo. So the second principles, the first one is to treat patients with severe symptoms. So irrespective of the cause, if the patient has severe symptoms, then the patient needs to be treated with IV 3% saline. So if you don't have IV 3% saline, then we can use the PO1. So irrespective of the cause, in acute symptomatic hyponatremia, and in those patients with a sodium level of less than 120 and with severe neurologic symptoms, then it is indicated to treat this patient with 3% saline. Once the severe symptoms are abated, then the second principle is to evaluate and defend the intravascular volume. So in patients with hypovolemia and hyponatremia, like secondary to dehydration, secondary to diarrhea, or secondary to vomiting and loss. So the first thing we need to do is to rehydrate these patients, unless if they didn't have a severe symptom. So hypotensive, dehydrated patients should be volume resuscitated with normal saline. So when we administer normal saline, because the normal saline has around 153 milli equivalent of sodium, which is mostly higher than the hypotonic serum, that will increase the serum sodium level. The other, when hypovolemia is corrected with the normal saline, so that will send a negative feedback to the baroreceptors, and there will not be release of the ADH. So there will be subsequent excretion of fluid, and that also results in an increment in the sodium level. So first, the saline by itself, because it is hypernatremic than the hyponatremic, the serum sodium level, that will increase the serum sodium level, which approximately by 1 milliequivalent per liter. And the other is by correcting the hypovolemia with normal saline. We also will remove the stimulus to ADH release. So thereby we're allowing excretion of excessive urine, excretion of excessive fluid in a diluted urine. So at the same time, the serum sodium may rapidly return toward this normal. So, but in some patients, we need to be cautious because this may result in over rapidly correction of hyponatremia, which may end up in osmotic demyelinating syndrome. So in patients with hypervolemic hyponatremia, in those patients without severe symptoms, so the mainstay of management is fluid restriction. But patients with heart failure, they may benefit from diuretics that increase the water excretion. And for patients with liver failure and hyponatremia, so diuretics will help, albumin will help, as well as paracentesis can also help in patients with cirrhosis and hyponatremia, which will help us in decreasing the total water amount in the extracellular fluid, and diuretics will help us in excreting the excessive water through the urine. So the mainstay of management, or the long term management for patients with hypervolemic hyponatremia, is water restriction. So in those patients with normovolemic hyponatremia, so the mainstay of management, like in those patients with SIDH, glucocorticoid deficiency, those patients with primary polydipsia and the like, where they are normovolemic but where they are hypovolemic. So the mainstay of management is free water restriction. So when we say free water restriction, so we need to restrict free water less than the urine output. So patient should have a negative balance. So the intake should be less than the urine output. But we usually target free fluid restriction of less than 800 ml per day. But if patient is severely symptomatic, water restriction alone can't reverse the symptoms, and the patient needs to be treated with 3% saline. If the cause of the SIDH is reversible one, like post-surgery due to pain and the like, so we need to nausea and vomiting, then we need to treat the underlying cause. Or if it is drugs, we need to remove the culprit drugs from the patient's drug list. But if the cause of the SIDH is not a reversible one, so we need to manage patients with fluid restriction, and they may need at times ADH antagonists. So we don't need to give normal saline for patients with SIDH. So because normal saline will result in a drop of the sodium level. So in clinical practice, so if SIDH is suspected, then normal saline should not be given. So the third principle is to prevent worsening hyponatremia. So identified medication taken by the patients that could cause or contribute to the hyponatremia should be discontinued unless there are none other drugs which replace the drug that the patient is taking. We generally need to reduce electrolyte-free water, and we need to restrict fluid, and we need to eliminate hypotonic intravenous fluids. And at times we can increase also the dietary salt intake. And if the cause of the hyponatremia is identified, it needs to be treated. So the last principle is, while managing those patients with hyponatremia, so we need to prevent over correction, which will result in osmotic demyelinating syndrome. So risk factors for osmotic demyelinating syndromes are, if the hyponatremia is severe one, less than 120, and in those asymptomatic patients, if the serum sodium is less than 110, in those patients with sodium level of greater than 120, we don't usually expect osmotic demyelinating syndrome. The other is easily reversible cause of hyponatremia, like hypovolemia and adrenal insufficiency. Like in adrenal insufficiency, when we administer glucocorticoids, then that may result in an easy correction of the sodium level that may result in a rapid overcorrection. Those patients with hypovolemia, as I mentioned earlier, they can be the sodium level can be reversed with hydration only. So these patients are prone to overcorrection. So those patients with SIDH due to transient causes like nausea, pain, or medication. So removing of these agents or treatment of the pain and will result in sudden increment in sodium level or the overcorrection of sodium level. So this type of patients, so we need to be cautious enough. At times, we may provide desmopressin, which is ADH agonists in patients with severe hyponatremia, which are prone to develop osmotic demyelinating syndrome, so that to prevent the excessive rise in serum sodium level. So desmopressin, it will act like ADH. So the other is high rate of correction. So if we correct the sodium by more than 8 to 10 milliequivalent per day, so that's also a risk factor for the development of ADH. And the greater risk occurs if the patient transition from chronic hyponatremia to directly to hypernatremia. So those patients with chronic hyponatremia who develop hyponatremia in greater than 48 hours, where there is brain adaptation. So brain will adapt to the chronic hyponatremia by removing some osmotically active particles and by decreasing the brain volume. So when there is a sudden increment in the sodium level, so there will be subsequent movement of water as well as solutes from the brain cells into the extracellular fluid, which will result in significant injury and shrinkage of the brain cells, which will end up in osmotic demyelinating syndrome. So the other factors like malnutrition, liver disease, alcoholism, patients with alcoholic patients, malnourished patients are also prone to overcorrection of sodium, and we need to be cautious while correcting sodium in this group of patients. So it usually develops between the 2nd and 6th day of treatment. And if it is identified early and treated accordingly, it is a reversible one. Most of the time, if it is not identified and if it is not treated early, then it will carry high risk of morbidity as well as mortality. So the treatment is correction of the sodium, which consists of giving D5W or loop diuretics, or at times, as I mentioned earlier, we may. So in those patients where there is a fear of overcorrection of sodium, we may administer desmopressin, the so-called desmopressin clamp regimen. And once we have given them that, then we can treat the hyponatremia. So this is all about the approach to hyponatremia, and I have mentioned the complication for treatment of hyponatremia, and thank you.
Thank you very much, Doctor. It was a very nice presentation, and I believe we took an ample amount of time in explaining the presentation. So we can Only choose one or two questions that you believe need to be addressed from the Q&A section, and we can conclude today's session.
One of the question is post-op surgical patient, can they develop hyponatremia? Yes. So post-op surgical patients, where if they are given a lot of fluid for like urologic surgeries for irrigation and the like, due to accumulation of the subsequent pre-water, that the patients may end up developing hyponatremia. The other is frequency of administration is not clear. So once you have calculated the amount of solution that it needed for to reverse or to achieve the target increment in sodium level, then you can divide that every hour. For example, in our patient, it is around 460. So if we are going to increase it within 24 hours, so then we can divide it by 24, which is approximately 20 ml per hour. So based on the target and based on the time, we need to calculate the amount of fluid needed to revert the hyponatremia. So for SOC and the severely symptomatic hyponatremia, should we give NS or 3% saline? If they are severely symptomatic, then we need to give a 30% saline, irrespective of the cause. But one thing, we need to look for overcorrection of hyponatremia. So the difference between SIDH and salt wasting syndrome. So patients with cerebral salt wasting syndrome, they are actually hypovolemic compared to patients with SIDH, who are normal volemic, but patients with cerebral salt wasting syndromes are hypovolemic. But in clinical evaluations, this may be difficult. So the other is the fractional excretion of urea after treatment of the hyponatremia. So if the fractional excretion of urea is high, despite treatment with despite treatment of the hyponatremia, then that gives us a clue that likely causes cerebral salt wasting syndrome. And the other is in clinical practice, we can, if there is, if we don't have a worry of overcorrecting the hyponatremia, then we can infuse normal saline and the C4 response of the sodium. So we can determine the sodium after giving a bolus of normal saline in 30 minutes to 1 hour. Then if there is a change in the sodium level, then that is cerebral salt wasting syndrome. But if the sodium level drops from the initial one, because we gave a normal saline, that will indicate that the patient has possible SIDH. So these are some of the questions, and thank you.
Thank you very much, Doctor. You have addressed all the questions written in the Q&A section. And on behalf of Blue Health Ethiopia and all our participants, we would love to thank you very much. And we had an amazing and well informative session. And we hope you will meet in another session with other topics as well. So again, thank you very much, Doctor. And at last, if you have anything that you want to add, let me give you the chance, Doc.
So coming to clinical practice, so the difficulty we usually have is means those severely symptomatic patients, because we don't have the IV 3% saline. So as a disparate measure, we can still use the PO 3% saline, which we can prepare it from the table salt and water in 1,000 ml of fluid. But still keep in mind that the calculated amount may not raise the sodium as expected with the IV fluid, but we can still practice giving them PO 3% saline through NG tube. Thank you for your attention.